Need Laugh here. Today, we're going to have a very interesting conversation. We're going to talk about the neuropsychiatric manifestations of HIV infections. Yeah, HIV. Now, remember, um, the treatment for HIV has been so effective that it's possible to um, not detect the virus in the peripheral blood system, right? But just because you don't find it in the peripheral nervous system doesn't mean that it's not in the central nervous system, right? So HIV has a predilection for the central nervous system. And even though you can test negative for it, it can still be there populating inside of the body. So because HIV has a predilection for the nervous system, then when we see patients with HIV infections, we also see some of the soft neuropsychiatric manifestations of the infection, right? And it typically shows up with inflammation. You know, when it comes to the brain and when it comes to creating psychiatric symptoms like psychoticism or mood related disorders or cognitive disorders, they always, almost always, is connected to inflammation somehow. And there's the mechanism. HIV typically results in some degree of inflammation. The inflammation disturbs the blood brain barrier. The blood brain barrier is no longer semi permeable and therefore lets everything in. And that's not good for a circuit system. It's not good to have everything floating around a circuit board, right? I mean, the central nervous system is a pristine environment where the whole brain, the brain and the spinal cord is suspended in a fluid, a cerebrospinal fluid. I call it holy water. I guess it's the closest thing to holy water you can get. Your nervous system is suspended in it. And that's a specialized fluid. When you open up the blood brain barrier, you disturb the space and nothing works in it. So we're going to look at today, we're going to look at HIV infection, the neuropsychiatric manifestation of HIV infections. Let me see. And here I have ChatGPT. Explain the neuropsychiatric manifestation of HIV infections, particularly focus on the disease process, explain the neuropsychiatric manifestations of HIV infection, particularly focus on the disease process and symptoms. Okay. Let me see what we have here. Okay, now we're getting here. Getting here. Okay, so let's see here. Okay. So here, explain the neuropsychiatric manifestation of HIV infection, particularly focus on the disease process and the manifestations of neuropsychiatric symptoms. That's my question. Excellent question. The neuropsychiatric manifestation of HIV infections are a major area of study because HIV is not only an immunologic disease, but it's also a neurotropic disease. HIV is not only an immunological disease, but it's also a neurotropic virus. Neurotropic virus, meaning it directly and indirectly affects the brain's nervous system. Let's break it down. So, yeah, remember neutrophils, right? Pathology, pathophysiology, how HIV affects the brain and nervous system. Okay. Neurotropism and CNS entry. HIV enters the CNS early in infection, often within days to weeks after exposure. I mean, this thing is rapid. The virus crosses the blood-brain barrier primarily inside infected monocytes and macrophages, a process called Trojan horse mechanisms. Wow. Once inside, HIV affects microglia and perivascular macrophages, the main immune tissue cells of the CNS. So basically, the Trojan horse pathology. Wow. The blood-brain barrier through macrophages, infected monocytes. So HIV gets into the nervous system by hiding inside of the immune system cells. Oh, okay. Molecular and cellular and molecular effects. Unlike other tissues, neurons themselves are not directly infected, but they are injured by neurotoxic viral proteins. Remember GP120, TAT, and VPR? Wow. Inflammatory cytokines, tumor necrosis factor, interleukin factors, right? Excitotoxicity via glutamate dysregulation, and oxidative stress via mitochondrial dysfunction. So yeah, so this is the interactions that the virus has with the cells in the nervous system. So this is interesting. So some of the proteins inside HIV are neurotoxic to the cells. So yeah, unlike other tissues, neurons themselves are not directly infected, but they are injured by the neurotoxic viral proteins, inflammatory cytokines, excitotoxicity, and oxidative and mitochondrial dysfunction. That's great. The result is neuronal injury and synapses loss, particularly in the basal ganglia, frontal cortex, and subcortical white matter. Wow. So HIV, it enters the nervous system through infected monocytes, macrophages. Then it can also enter the nerve cell, the tissue, brain tissue itself through the microglia and the perivascular macrophages, right? Okay. Then the proteins itself can cause the cell to malfunction. In response to the virus, the immune system will produce inflammatory cytokines such as tumor necrosis factor, interleukins, things like that. And of course, these generate more of an immunosuppressive response. Then through excitation, remember, glutamate, go to the lecture I have on glutamate, the neurotransmitter glutamate. And remember, glutamate is the main excitatory neurotransmitter. So basically, excitotoxicity via glutamate dysregulation. So you turn the glutamate on, then basically you have a situation where you're going to ride till the wheels fall off, right? Okay, then oxidative stress and mitochondrial dysfunction. This is where you decouple APD, you decouple the production of ATP, right? I think this is the oxidative stress and mitochondrial dysregulation. The result is neuronal damage, injury and synaptic loss, particularly the basal ganglia. So basal ganglia, frontal cortex, and the subcortical white matter. That's the cellular and molecular effects of HIV. Okay, HIV-associated neurocognitive disorder spectrum. The hand spectrum captures the neurocognitive decline associated with HIV. Yeah, that's one of the things we want to follow too, is this neurocognitive decline in HIV. Asymptomatic neurocognitive impairment. Mild deficits only detectable by testing. Yep. Asymptomatic neurocognitive impairment. Yeah. See, I picked up a mild neurocognitive disorder. Mild neurocognitive disorder, mild dysfunctional impairment in daily activities. HIV-associated dementia, severe cognitive and functional decline, historically called AIDS, dementia complex. Okay, great. Asymptomatic neurocognitive impairment. I always looked at that as the same as mild neurocognitive disease disorder. Okay, neuropsychiatric manifestations. HIV can cause a wide range of neuropsychiatric symptoms due to both direct neurobiological damage and indirect psychosocial factors such as stigma, chronic illness, and medications, etc. Okay, so HIV can cause a wide range of neuropsychiatric symptoms due to both direct neurobiological damage and indirect psychosocial. Okay, cognitive and neurologic manifestations. Cognitive, memory impairment, of course, if the networks are not functioning well, particularly if you're getting hippocampal dysfunction. And like it said here, this Okay, it didn't say the hippocampus here, but yeah, basal ganglia, movement disorder, frontal cortex, executive thinking, personality, planning, white matter, and things like that. That's sort of like this. It's sort of like multiple sclerosis type neuropsychiatric manifestation. Okay, slow information processing because none of the the hippocampus not working, the basal ganglia, the process is not working. Executive dysfunctioning meaning, okay, frontal lobe damage here will lead to the executive dysfunctioning symptoms here. The slow processing information is still a part of this frontal cortex and the subcortical white matter. Psychomotor slowing. Sure, the basal ganglia is supposed to regulate movement. That's how you get that. Attention deficits. I mean, these are frontal cortex damages, right? Language disturbances, basically frontal cortex, also the temporal lobe too, and the Broca's aphasia area. Gait abnormality, tremor, spasticity, or late stage is still the basal ganglia. So when you see, okay, the result is neuronal loss and synaptic loss, particularly in the basal ganglia, the frontal lobe, and the subcortical white matter. So when you're examining patients with HIV and you're looking for the soft neuropsychiatric manifestations of HIV, then you start to look for movement disorders here, cognitive problems, right? And then other things like perceptual and movement disorders too. So they may not be as prominent, so they come up as like asymptomatic and mild neurocognitive disorder, but you can pick them up there. You can pick the deficits up there because they'll have difficulty paying attention or paying to concentrate. So look here, look, memory impairment. They'll have difficulty remembering things. So you want to test their short-term memory, right? You want to test their working memory, meaning the number of items that they can hold in memory at one time. And then you want to see about their long-term memories. Short-term memory, what did you eat yesterday? Working memory, why don't you remember these 12 items for me? And long-term memory, what streets did you come? What high school did you go to? You know, slowed information processing. Okay, look. Okay, these reflect subcortical dementia, characterized by slow thinking, apathy, motor dysfunction, rather than the amnestic pattern of Alzheimer's dementia. Now, remember, the amnestic pattern in Alzheimer's disease is only amnestic because it only involves the hippocampus, right? Alzheimer's, initially, it only involved the hippocampus. It's the acetylcholine receptor nerves that die, right? And so you get a reduce in memory, but shouldn't involve things like perception, things like mood, and all that. That's why with Alzheimer's disease, they're very forgetful, but it's a gradual transition, right? But here, when you're talking about HIV, neuropsychiatric manifestation of HIV infection, look, you having memory problems again, you having processing problems, you having thinking problems, you having movement problems, you have executive functioning problems, you having language problems, you having gait problems. That's different than just Alzheimer's just affecting memory, right? So when they say of subcortical dementia, you're talking about damage to a lot of structures subcortically, and that process primarily happens through what we're describing here. When this exocytation, this process here damages the cells. Okay, here psychiatric manifestation. Just look at this. Now, let me try to simplify this for you. So it's very easy for you to sort of remember and begin to understand. No matter whatever dysfunction you have, it's only going to produce certain symptoms. You mess the system up, you're going to get a psychosis, right? Or you're going to get a mania, or you're going to get a depression, or you can get anxiety, or you get nothing, like cognitive problems, right? You can only fail within certain categories. There's not a new brain failure category, luckily, because you only fails in certain only predictable ways, right? So let me show you here. So look here. So when things fail, psychiatric manifestation, look, depression, look, mania, look, psychosis, look, anxiety, and then look, not only sleep, but other cognitive things that's based upon routine, like your appetite, your weight, your sleep, your interest, your motivation, and things like that. So it started to affect those, right? So failure results in mood problems, like problems, because think about this. Think about this. When if you're having a virus impact your brain and your brain is responsible for interpreting your reality, all right. If that virus interferes with the functionality of that network, then you're going to have a different reality. The problem is the person with a different reality believes that all that stuff is real, but it's just the impact that the virus is having on their networks that's rendering their reality. Got me? So these symptomatology represents malfunctioning in the network. It's not even personal. The person feels very depressed, sad and withdrawn and just feeling absolutely awful. I mean, you grow when you can look at them and say, hey, this is just a decreased serotonin story. Oh, the serotonin low. Oh, if the person really psychotic believe all these different, oh, the dopamine is just too high, right? If they can't sit down, if they keep moving, if they're talking all the time, yelling, screaming, arguing, or fighting, man, yeah, they just have too much norepinephrine dopamine, right? The stories are connected to to what's happening at the receptor and the neurotransmitter level. The story isn't the reality. The reality is what's happening on the network. The story is just the production, right? So here, depression, look, depression, most commonly in 50% of the studies. Look, the mechanisms, neuroinflammation. I told you there's that inflammation again. Look, serotonin, involving serotonin. I told you, right? If those serotonin networks start failing, they're going to present with depression. And then dopamine too. It's a dopamine story too, but more of a depression story. We'll get to the dopamine story later. Read the look at the the podcast on the dopamine as a neurotransmitter and see how important that is. Psychosocial stressors, um, mechanisms, psychosocial stressors, and immune dysregulation. Look, cytokine induced sickness behavior. Cytokine induced sickness behavior. Right. When the patient's serotonin levels begin to drop and the dopamine levels begin to drop, they exhibit their networks become hypoactive and they exhibit hypoactivity, right? But then they actually play along with a depressed role too. So when the networks are sort of hypoactive, sure, you get the psychomotor slowing, you get the psychomotor retardation. You start to feel tired. You have different. Your thoughts start to slow down. Not as much interest, not as much motivation, and then all of a sudden you start like playing a sick role, playing like you're depressed when really your networks are just hypoactive, making you experience a state of depression. Yo, got me? Look, when things go haywire, when it goes up, it goes up. When it goes down, it goes down. Look here, mania, bipolar like. Look, mania and bipolar like syndrome. HIV associated mania or AIDS mania can occur, especially in advanced diseases. I don't think there's anything such as AIDS mania. I think that if you start to get that glutaminergic system hyperactive, you make those glutaminergic system hyperactive. I think you're gonna get everything turned up. Let me just tell you this to make it simple for you. You need to look at the presentation I did on glutamate and GABA. There are two main neurotransmitters that's present throughout basically all the tissue. One is glutamate, and remember, it turns everything on, and the other is GABA, and it turns everything off. The main story is a story between glutamate and GABA, and here this HIV, I guess they're saying HIV-associated mania, meaning, look, mania is this characterized by irritable disinhibition and hyperactivity, right? These seem to be complex manic symptoms that seem to be mania associated with other symptoms like cognitive symptoms and also perceptual disturbances. So this is more than just like mania, right? So they say like AIDS, mania, meaning when you see patients with HIV having mania, the mania is different than just the patient just with bipolar having mania. It is a huge difference. I mean, it's a huge difference. The degree of irritability is too intense. I mean, the level of disinhibition is off the chain, and the level of hyperactivity is unpredictable. I mean, with treating this disorder when the patient is exhibiting mania means you have an emergency on your hand. I mean, this thing can really get out of hand. So you're going to have to make sure you stay in control of watch for these manic type symptoms. And the person is on the ride. They're not able to stop themselves. It's like the avatar goes in its own mode. And unfortunately, they're stuck on it. They're stuck on the ride, and they can't stop until someone like you comes around and help them explain what's going on and why they would need the right medications. Um, Here, psychosis can present as HIV-associated psychosis, paranoia, delusions, auditory hallucinations, often occur with cognitive disorders. Mechanisms may include basal ganglia dysfunction, neuroinflammation, and dopaminergic dysregulations. Now, remember, okay, let me go back here. For depression, think about serotonin. They also said low dopamine levels too. Yeah. Someone take cocaine, their cocaine after when they enter withdrawals, they have low dopamine levels, and it's very difficult for them to get out the bed in the morning, right? They have to let them sleep for that day after cocaine withdrawals. Depression here. So think low serotonin, dopamine, norepinephrine, and also norepinephrine levels too for dopamine too. For mania, think about excessive serotonin, excessive norepinephrine, and possibly excessive dopamine also. And here, however, psychosis is a dopamine story. It's an excessive dopaminergic story. So in the psychosis, excessive dopamine stories sound like horror movies, right? Depression sounds like love stories, right? Heartbreak stories, right? Low serotonin. Mania, Super Bowl. Man just won the Super Bowl. Where you gonna go? I'm gonna go to Disney World, right? So these are stories connected to neurotransmitters. And understand with psychosis is dopamine. And remember paranoia, right? Horror movie, you did this to me, they did that to me, right? Delusions. You did or you didn't. You did. You did. Is it? What word? Is it? Is it's not? We're really auditory hallucination. That's a dopamine story, right? When you start getting scared, when you start getting nervous, when you start feeling dopamine, right? Too much dopamine. Often the co-occurs with cognitive decline, right? Mechanisms may include basal ganglia dysfunction, neuroinflammation, and dopaminergic dysregulation. There we are right there, the dopaminergic dysregulation and everything is too much dopamine, and now the paranoia, delusions, auditory hallucinations, and mainly the positive symptoms of schizophrenia start to kick in. All right, then of course, anxiety disorder, you start moving around these serotonin, norepinephrine, generalized panic attack, PTSD, common, often secondary to chronic stress, illness, and uncertainty. Okay, great. Sleep disorder due to cytokine imbalance, alter circadian rhythms, or medications. So I typically put patients on things like melatonin to sort of help them with sleep at night. Okay. At this point, let me see if I have any questions right now. Let me see if I have any questions. Mohammed, how's it going, buddy? Nice to see you too, buddy. And Latrice, thanks for checking in, Latrice. And for the students, can y'all start checking in? I want to make sure y'all did these lessons. I gotta find a way to keep up with students. I don't even know if y'all are watching this lecture or not. Let me see. Okay, let me go ahead. Okay, so medication-related neuropsychiatric effects. Okay, and so let's go ahead and I don't really want to cover these. The treatment for HIV, I just want to go ahead and progression and correlation. Acute, chronic, asymptomatic, and advanced. Acute, transient encephalopathy, meaning acute confusion, cytokine storm. This cytokine storm is bad. Headaches, confusion, and mood lability. That's like that initial infection, right? Asymptomatic, chronic asymptomatic, low-grade inflammation. Subtle cognitive decline, subtle cognitive slowing and depression, advanced age, HIV encephalitis, neuronal loss, white matter disease, dementia, psychosis, mania, motor abnormalities, the same areas we're talking about, right? Diagnostic consideration, neuroimaging, an MRI shows white matter hyperintensities, atrophy of the basal ganglia and the frontal cortex. So remember that basal ganglia frontal cortex combination. CFS analysis may show elevated proteins such as HIV RNA. The neuropsych testing identifies hand stages. Yeah. See, the neuropsych testing is how you're going to be able to identify all the different areas here, like the cognitive decline, the functional impairments, and things like that. That's how you're going to, because with the neuropsych testing, you're going to be able to test their memory, you're going to be able to test their abstract reasoning, be able to test their executive functioning symptoms. Okay, yep. And then here, okay, so here's, I guess it's the mechanism. Okay, did I do this one? Okay, management, early and consistent entry. Okay, I don't want to get into management there. Mechanisms. Okay, the viral protein. The viral protein is one of the ways that the virus, the GP120 or something else, is the way the virus can create the neurotoxicity, and that results in cognitive slowing and apathy, right? Apathy is a very significant one. That's when apathy can be, that's when there's simply like no emotional response at all. It's really stunning when you're talking to patients who have real apathy. It's like you're in a room with a vacuum, and like everything comes out, nothing echoes back. It's like that. But the apathy is usually associated with movement disorders, particularly in the basal ganglia. So the HIV's predilection for the basal ganglia may be one of the reasons why the cognitive slowing and apathy can be so much very prominent. Okay, this cytokine-mediated storm, right? Okay, neurotransmitter imbalance, great, yeah. So it makes an imbalance the neurotransmitters in the synaptic cleft. The frontal striatal circuit damage, executive function. Yeah, here it is. So it's that frontal striatal circuit damage. Did I do, I think I did a presentation on the frontal striatal pathway. Let me see, did I do that? Let me see. Dorsolateral, we did the dorsolateral. Okay, great. About the dorsolateral prefrontal cortex, amazing. This is very important right here, the dorsolateral prefrontal cortex here. So I think the next one I'm going to do is on this circuit here, the frontal striatal damage here. I'm gonna put that down. Let me put that down for tomorrow. Let me look here. So I'm gonna do this one tomorrow noon. Okay, frontal striatal pathway. Okay. So it's damage to this circuit that causes the executive functioning system, the executive functioning difficulties, which results in disinhibition, right? The purpose of the frontal lobe is to shut things down. Remember, in attention deficit hyperactivity disorder, this network is hypoactive, right? Because it's hypoactive, the frontal lobe is not as dominant or is not as engaged in turning things off. So we give people stimulants not to stimulate their body, but to stimulate this pathway so that the frontal lobe can be more dominant, and therefore it can trigger suppression and inhibiting everything around this. So the clarity of thought and the consciousness you enjoy is because your frontal lobe is suppressing absolutely everything except that one thought you want to have, right? So that inhibition is limited at that point. Here also mania, right? I believe left-sided frontal lobe injuries, I think, associated more with depression, and then right-sided associated mania. But look that up. Each one of those, one is associated more with depression more, and the other associated more mania. So with that frontal lobe damage, you get the mood disorders, right? You also get the personality changes and the personality disruptions also. So um, the person loses the ability to read social cues, and the judgment and things like that become skewed. So they start to have a lot of interpersonal difficulties. But apparently, HIV damages that network. Okay, ART side effects, neuropsychiatric symptoms, insomnia, vivid dreams, anxiety. Would you like me to include a schematic or visual diagram show how would you like me to include a schematic or visual diagram showing how HIV invades and affects the CNS and leads to these psychiatric outcomes? Why, yes. It would make a disease process much clearer visually. Why, yes. Um, okay, so what I do? Okay, do yes. And then what it do from there? Hey, hey, hey. Let me see what's happening here. I guess it's going to take time to generate it. Be interesting to see. Be interesting to see what it comes up with. Uh-oh. And this is moving fast, y'all. I don't think we're gonna need textbooks anymore. Okay, let me see. Oh, I think it's coming. Still rendering, folks. I can't wait to see. I think it's gonna be really nice. I can't wait to see it. Almost there. Almost there. I think just a little bit left. Well, let me do this then. I'm a. This is the free version. Well, let me move on. I think that's it. If it comes on, I'll let you guys know. Oh, okay. Oh, here it is. Here it is. Okay. So here, neuropsychiatric manifestation of HIV infection, pathology, the brain effects and magnification. HIV, infected monocytes, infected macrophages, right? Release of cytokines, glutamate. Glutamate causes the release of cytokines. It primarily affects the basal ganglia, particularly subcortical white matter, and the manifestation is cognitive slowing, apathy, depression, and executive function. This is great. And then, I think this diagram only includes all of the important parts of this. Yeah, look, monocyte, macrophages, cytokine, glutamate, basal ganglia, subchondral myosin. Yeah, this is great. Well, I think that's all I need for now, guys. Uh, Again, it's a pleasure to work with you guys. It's a pleasure. Um, if you have any other questions, feel free to give me a call. I mean, feel free to leave a question in the answer in, in the comment section, and feel free to like, subscribe, and share. Okay. Hopefully, it's very helpful for you guys. Take care, guys. Read out. Ciao, guys. What's going on, guys? How's it going? Today, I was going to review the frontostriatal pathway. It's a very important pathway to sort of understand, particularly if you're trying to sort of get a good idea of what's going on with the patient. For the most part, you look at the cluster of symptoms the patient's having, and you try to trace it back to the lobe. And then you see what are the networks in that part of the brain. And then that way you can sort of drill down on the circuitry to get a good idea of what's causing the disturbance. You know, if you know what the receptors are like on this pathway, then you have a good idea of what tools you can use to intervene. So here I'm on Chat GTP. And just let me just ask it here. Okay, let's see here. Explain the frontal striatal. Explain the frontal striatal pathway. Function and focus on the functions and receptor profiles, right? Okay, we're about to get into this. Okay. Okay, let's see here. Okay, let me go ahead and start up here. Okay, excellent question. The frontal striatal pathway, also called the frontal striatal circuit or the frontal striatal loop, is one of the most important brain systems linking the frontal cortex to the basal ganglia and the thalamus and playing a central role in motivation, reward, cognition, emotion, and executive function. Understand this. This is very important to sort of understand this. So this connects the frontal lobe to the basal ganglia and the thalamus, right? The frontal striatal pathway, all right, playing a critical role in motivation, rewards, cognition, emotion, and executive functioning. Yeah, because that frontal lobe, you want to connect that frontal lobe and get the input for that executive functioning. Let's break it down. For the anatomy, the frontal striatal pathway connects the frontal cortex to the striatum, to the globus pallidus and the substantia nigra, to the thalamus, and then back to the frontal cortex. This creates a closed loop circuit, meaning the output feeds back the same cortical regions that initiate the signal. The frontal striatal loop. Frontal lobe, especially the prefrontal areas, such as the dorsolateral, orbital, frontal, anterior cingulate cortices. Next to the striatum, the caudate nucleus, and the putamen. Then the globus pallidus, the pallidum, and the midbrain, substantia nigra, and the ventral anterior mediocre nuclei. Yep. And back to the thalamus, the frontal striatal pathway. Okay, the functional circuits within the pathway. These are several parallel frontal striatal loops, each serving a different function. So, for example, the motor loop, okay, the frontal organ, okay, you have the oculomotor loop, you have the dorsolateral prefrontal loop, the orbital frontal loop, and anterior cingulate loop. Okay, so let me just try to organize this. Okay, The motor loop, okay, it originates in the motor area through the putamen, and movement, it initiates and control motor movement. That's the motor loop, all right? Okay, there are several parallel frontal striatal loops, each serving a different function. The ocular motor loop, frontal eyelids, the caudates, and this is for eye motor movement. Yep. Look, dorsolateral prefrontal loop. Dorsolateral prefrontal loop. Wow, man, we have to look at that dorsolateral prefrontal loop next, because the dorsolateral prefrontal cortex is thought to be the seat of the ego, and that's what we're trying to sort of dismantle. So the dorsolateral prefrontal loop, the dorsolateral caudate, again, look, executive functioning, look, working, memory, and planning. Very important. Orbital frontal loop. The orbital frontal loop, the ventral medial caudate, for impulse control, reward, evaluation, emotional regulation. Damage to that orbital frontal loop, impulse control, reward, drug seeking, emotional regulation, impulsive behavior. Anterior cingulate loop, the anterior cingulate cortex, a ventral striatum, this motivation, drive, conflict, monitoring. And so there are several frontal parietal loops. Great. And so they come from the cortex to the silent. Okay, great. Okay, core functions. The frontal striatal circuits integrate cognitive, emotional, and motor control. Yeah. Selecting and initiating actions such as motor and cognitive, suppressing inappropriate behaviors, mediating reward-based learning, linking motivation, that is goal-directed behavior, and regulating executive control such as planning and decision-making. Next, damage or dysregulation can lead to executive dysfunction signals. Yep. Mood and motivational changes, movement disorder such as Parkinson's disease. Yeah. See, remember, is one of the pathways that's sort of injured in schizophrenia too, and I think the degradation, damage to this pathways may be the mechanism that creates the diminished sensorium, or the cognitive differences, the cognitive damages or cognitive differences in patients with schizophrenia. So let me just review this again. You have this frontal striatal circuits. They integrate cognitive, emotional, and motor control, right? Remember, in schizophrenia, the diminished cognitive processing things, the diminished emotional range or apathy and things like that. And then also with schizophrenia, the motor movement, things like that. So, so damage to this frontal striatal circuit, as you can see how you can sort of see the areas that the patient will have the most dysfunction in, meaning cognitive areas, emotional areas, or movement disorders area. Next, selecting and initiating actions. Yep. Suppressing inappropriate behaviors, mediating reward-based learning, linking motivation such as goal-directed behavior, regulate executive control such as planning and decision-making. Damage or dysregulation can lead to dysexecutive syndrome. See, there's another name that I use for here. It's called executive dysfunction. So this is there are persons behaving in a way that shows no planning or organization. It's just random behaviors and reactions, blind and unconscious reaction from their ego in response to their ego. So this executive syndrome, such as schizophrenia, ADHD, and frontotemporal lobe dementia, right? Mood and motivational changes such as depression, apathy, or OCD. Yeah, OCD, movement disorder such as Parkinson's disease. So remember, the cognitive, the emotional, and things like that. See, the cognitive and emotional, that would be frontotemporal lobe dementia. Motor would be sort of like Parkinson's disease and things like that. Okay, so let's look here next. Receptors, the neurotransmitters and receptor profile. The frontal striatal system depends heavily on dopamine, but also involves glutamate, GABA, and serotonin. Dopamine, origin substantia nigra, okay, and VTA, ventral tegmental area, projects to the striatum. Okay, the receptors, D1-like receptors, mainly on the direct pathway, D2 receptors on the indirect pathway. Okay, So we have dopamine receptors, D1 receptors, D2 receptors. Okay, we also have glutamate receptors on the pathway. The cortical inputs to the striatum is glutaminergic, excitatory. It acts on NMDA, which is a type of glutamate receptors, and AMPA, which is another type of AMPA, which is another type of glutamate receptors. They mediate top-down control and goal-directed activation. So let me go through this here. So this frontal striatal circuits, so is primarily heavily dopaminergic. So it involves D1 and D2 receptors. So if the patient's having difficulties in this area, then the antipsychotic medications, particularly, and the antipsychotic medications can be used. Now, the typical antipsychotics like Haldol and Prolixin, they primarily bind D2 receptor, right? But the atypical, they also bind D1, D2 receptors and the other receptors too. So both typical atypical antipsychotics can be used in this situation. Okay, here, and then of course glutamate is the main excitatory neurotransmitter, and so of course the cortical inputs from the striators is glutaminergic, and so of course when it activates those pathways, it's going to activate glutamate because you need to get things turned up, right? Okay, next, the other major neurotransmitter that turns everything off is GABA. Glutamate and GABA are present in practically all of the tissue. And so when you activate glutamate, you get a systemic response of activation. When you activate GABA, you get a systemic response of inhibition. So glutamate turns the whole organism on and up, and GABA turns the whole organism off and down, right? And so the cortical inputs to the striatum are glutaminergic, excitatory. NMDA is one of these type of glutaminergic receptor. AMPA is another type of glutaminergic receptor, right? GABA, this is the main neurotransmitter within the striatum. Okay, this is the main, I guess it has to be the main one to shut things down, right? Medium spiny neurons are GABAergic neurons that inhibit output nucleus, right? They provide inhibitory control within the loop. So the main neurotransmitter in the striatum is an inhibitory neurotransmitter, glutamate, GABA. And alcohol is a target for GABA, right? And so this is one of the reasons how alcohol can influence the person's perception of things. Because look, remember, we're talking about this frontal striatal circuits, and the main neurotransmitter is GABA, and GABA is the target of alcohol, right? And so remember, alcohol impairs the frontal striatal circuits, and you get the executive dysfunction system. Like, why did you do that? I don't understand that. You get the mood disturbances and the motivational changes and things, and then you get the movement issues like severe agitation, combative aggressive behavior. This you can see how alcohol is not a good selection of substances to use if you have any type of challenges to the stability of your frontal striatal circuit, right? Because otherwise, when it hits those switches and then you start having all these difficulties because it's a malfunctioning frontal striatal circuit, then the consequences can be very severe, right? So the main neurotransmitter within the striatum is GABA, and GABA provides inhibitory tone, right? Okay, next, also serotonin, acetylcholines, and others. Serotonin modulates motivation and impulsivity via the 5-HT1B, and acetylcholine from the striatal interneurons regulate dopamine release and plasticity. All right, sounds good. And so remember, also for this glutamate GABA issue, if the patient coming in with these issues, Depakote is a option for this, because Depakote will increase the level of the threshold for a action potential, and it will have the overall effect of slowing the traffic down across the network And Depakote will also, in addition to lithium, will also cause long-term downregulation of those glutamate receptors. And so patients with the psychosis, schizophrenia, psychosis, mood, or substance abuse disorders that may have damaged or injured their frontal striatal pathway, we can use Depakote to sort of stabilize that pathway by hopefully resulting in the long-term down regulation of glutamate that's very excitatory and upregulation of GABA, which is very inhibitory. So hopefully the medication over time help balances the receptor profile so the patient exists in a more balanced, peaceful state, not in a hyperglutaminergic state. Got me? Great. Look, clinical relevance here. Okay, for Parkinson's disease, the loss of dopaminergic neurons in the striatum, decreased D1 or 2. Okay, great. Schizophrenia, dysregulated prefrontal dopamine. Schizophrenia, dopamine, prefrontal dopamine, glutamate dysregulation. Look, hypofrontality and working memory deficits. That hypo for that see in schizophrenia, dysregulated prefrontal dopamine glutamate, meaning the frontal lobe can have hypoactive dopamine. It can be hypodopaminergic, and therefore one of the antipsychotics, Abilify, works very uniquely because Abilify is a dopamine agonist, not a dopamine antagonist. It's just that it activates dopamine just a little bit, not a lot. So overall, it can significantly decrease dopamine hyperactivity simply because it activates a little dopamine at a time, not just a lot of dopamine. So medications like Abilify as an antipsychotic can be used to sort of help stimulate dopamine production in areas of the brain that are hypoactive, such as this. Okay, in working memory deficits, you may need to sort of add something like acetylcholine or something for memory to help with the working memory deficits. Look, ADHD, reduced dopaminergic and noradrenergic tone. Right. And look, frontal striatal hypoactivity. So you don't have as much executive dysfunction. You don't have as much executive functioning, meaning planning, organizing, multitasking, sequencing, because the executive functioning comes from this frontal striatal. And so when you add a stimulant, you're stimulating this frontal striatal circuit, right? So it can become more dominant, and then the frontal lobe can impose more executive functioning tone over the environment. Look, OCD, hyperactivity in orbital frontal loop. Look, excessive error mark. There's hyperactivity in the orbital frontal loop, meaning this orbital frontal loop lost the brakes. And now the circuit is just going on and on and on and on. I need to go through that orbital frontal loop, and we need to sort of increase serotonin as much as possible to try to put the brakes on that circuit. And every time the person goes through the circuit fires, the person has to go through the repetitive stereotypical behavior. And that's what causes this excessive monitoring, OCD. Also, depression, hypoactivity in the ventral striatum, that is the reward circuit, right? Anhedonia and apathy, right? That mesolimbic pathway, hypoactivity, hypodopaminergic activity in the mesolimbic pathway causes anhedonia, decreased interest, decreased motivation. It's the reward center. It's why people use substances to activate the mesolimbic pathway. And so in depression, you see the hypoactivity in here also results in anhedonia and apathy. Let's see here. Neurotransmitter. It says here, would you like me to include a diagram or schematic summary showing the direct and indirect frontal striatal pathways with receptor locations and neurotransmitters labeled on it? Will help you visualize. Let me push yes. This is great. And then while it's making that, I'm gonna go through this. Okay, the neurotransmitters, the major receptors, the role in the frontal striatal circuit. So neuroreceptor, dopamine, glutamate, GABA. Remember, GABA is the major one in the circuit. serotonin, acetylcholine. Okay, dopamine. Sure, D1 is excitatory, D2 is inhibitory. Right. Reward, motivation, cognitive flexibility. Right. Okay. D1 make it hyperdopaminergic. That means that that means that the you get more attention, more concentration, more pleasure, more increased rewards, and things like that. D2 is inhibitory. Okay. All right. Glutamate is active, is excitatory. Again, there are made two major neurotransmitters in every tissue, glutamate and GABA. So glutamate, that's one NMDA receptor. Ecstasy is a drug that actively activates NMDA, and it activates it so much it goes through the excitatory process where the cell dies, and because things are turned up too much, you lose the brakes. AMPA is another type of glutamate receptors, and of course, excitatory cortical output. All right, and so starting from the cortex, those fibers going from the cortex down here, like the frontal striatal pathway, going from the frontal lobe down to the striatum. It's excitatory. It turns things on, right? And the glutamate is the neurotransmitter for that. GABA A, GABA B, inhibitory control, and I believe it's GABA B is the site of alcohol, right? And I think GABA A is the site of benzodiazepines. I think one of the two. Make sure y'all get that right. And so, alcohol and benzodiazepines like Xanax and all that, this is simply activating GABA that's going to exert inhibitory tone. Why? Because there's too much glutamate, right? Too much glutamate. Serotonin. Okay, 5 serotonin receptors modulate mood and impulse control. Okay, great, we got that. Acetylcholine, the M1 for muscarinic, striatal modulation and learning. Okay, we got that. But so mainly dopamine. So if we want to sort of maintain some control over this network, we want to make sure that we can use our antipsychotics that target dopamine. Now, remember, glutamate receptors and GABA, see, be careful with long-term. I wouldn't suggest long-term benzodiazepine use. You may want to use it in a short term, particularly longer-acting benzodiazepines like clonazepam or Klonopin, but I certainly wouldn't agree with short-term anti-anxiety medications, benzodiazepines. So remember, glutamate and GABA, depakote and lithium causes downregulation of glutamate and upregulation of GABA. So depakote and lithium in combination will be a very useful mechanism to stabilize this. So as you can see, if the patient is having any type of psychoticism symptoms, meaning delusions, paranoia, or negative symptoms, poverty of thought, withdrawn, apathy, there can be destabilization definitely in the dopamine networks. In the dopamine networks, if the patient is overly excited or combative for activation, that's over activation of the glutaminergic networks, right? If the patient is let's say disinhibited, doesn't have the brakes, unable to stop, exhibiting very poor judgment, crossing a lot of boundaries, this may be a GABA issue, a failure of inhibition. So there's no brakes, and so there's no brakes because there's GABA. There's not as much GABA activity. If they present with, like anxiety, depression, anxiety, restlessness, and everything, it's a serotonergic story. Same thing with acetylcholine. You see here learning and memory, right? Memory, acetylcholine, Alzheimer's disease, right? And so you see here acetylcholine for Alzheimer's disease. Okay, so this is looking great. So as you can see how, if you understand the receptors on this network, then you sort of have a good idea of what medications you can use if you start seeing these type of symptoms, like over here, these symptoms the patients are going through. So here, this is a diagram of the direct and the indirect frontal striatal pathways with the receptors locations and the neurotransmitters labeled. Okay, I think it is what it is. Okay, the direct pathway. Okay, direct pathway, indirect. Okay, yeah, I'm not sure I'm getting this. But I think that's all I want to say for now. This is a frontal striatal loop, the pathway. Hey, Keep in mind when you start seeing patients with these type of symptoms. Okay, I think that's all I need to say for today, guys. If you have any questions, please feel free to subscribe, like, and share. Otherwise, take care, guys. Read out. Hey guys, how's it going? Reed here. We're about to have a very interesting discussion. A very interesting discussion on lithium and the signal transduction cascade. This is part two. Go back to the previous podcast I did on the signal transduction cascade. And from there, you'll see how the signal transduction cascade is the mechanism that transfers the signal from the receptor to the cell body. The ligand binds the receptor on the outside surface that goes through a signal transduction cascade process, and then the product of that is sent to the cell body so the cell body can produce a response, which is typically a product that can likely be exported out the cell or placed on a cell membrane, right? So it's important to know, and this is very important because what happens is that when you are treating patients and they have a partial response, that implies that you likely blocked all the receptors on the postsynaptic receptor. You blocked the majority of the receptors, and you're not getting the response you want. The problem is that it may be problems within the signal transduction cascade in and of itself. And guess what helps with that? Lithium. Lithium helps with the steps of the signal transduction cascade by making it work better, it perform better, and it increases more stability for the entire cell. So we're going to go through that. Lithium is a very important medication. Okay, let me see here. I got hot sauce and fish. I got fried fish and hot sauce in the back of my throat. Jeez. Fried fish and hot sauce. Catfish nuggets and hot sauce. Okay. Explain. Explain the role of lithium in the signal transduction cascade. Okay. Lithium, widely used as a mood stabilizer in bipolar disorders, has multiple biochemical effects on signal transduction cascades in the brain. Its therapeutic effects range from modulating intracellular signaling rather than from direct effect on the neurotransmitter receptors, right? Its focus is not the receptor, it's the activities that happens after receptor bound. Jesus, sorry about that. I got catfish granules in the back of my throat. Okay, so let's see here. Okay, so here, it doesn't bind directly. The effects is not directly on the receptor, the neurotransmitter receptors. It modulates the intracellular signaling, the things that happens inside the cell. Overview, what lithium does in signal transduction. Signal transduction cascades are how cells convert an external signal, like a neurotransmitter binding on a receptor, to an internal response, such as a gene expression or ion channel charges. Lithium acts downstream on neurotransmitter receptors, meaning it influences second messenger systems, especially the phosphoinositol system and the G protein signaling cascades. So look, lithium acts downstream of the neurotransmitter receptors, right? It influences second messenger systems. One, the phosphoinositol system, and two, the G protein cascade system. Key targets and pathways. Inhibition of inositol monophosphate, right? Modulation of G protein coupled receptors, right? And then C here, the effects on protein kinase pathways. Great. Inhibition of inositol phosphatase. Now, this is amazing. Basically, it prevents the recruitment of PIP1 so that you don't have enough PIP1 to make PIP3. Very interesting. In a normal pathway, the neurotransmitter binds the G protein and that activates phospholipase C, which cleaves PIP2. That produces PIP3 and DIG. Now, PIP3 releases intracellular calcium. Right now, so remember, PIP2 is broken down into PIP3 and DAG. Right? Now, this IP3 causes the release of intracellular calcium. Now, in sort of recycling, if we want to recycle IP, make more IP3, then we take inositol and we reuse it to make PIP2. Oh, wow. So PIP2 plus inositol makes PIP3 plus inositol makes PIP2, as opposed and PIP2. Okay. Skip that. Okay. So lithium roles. Lithium inhibits inositol monophosphatase and inositol polyphosphatase 1 phosphatase and blocks the recycling of inositol. So it blocks the recycling inositol. Okay, so you need inositol in order to get PIP2 back to PIP3 back to PIP2. Like here's PIP3 right here, which is that, and you want to get back to PIP2, so you need inositol in order to get to PIP2, then it's cleaved again. Yeah. So lithium blocks the recycling of inositol. Okay, this leads to the depletion of PIP2, right? Right, PIP2 is cleaved there. So it leads to the depletion of PIP2, reducing signaling through G coupling receptors. So it decreases the production of PIP2 and depletes the production of PIP2, and therefore it reduces the signaling. Okay, great. That's the feedback. Okay. Reduced overactive signaling in circuits linked to mood dysregulation. This is known as inositol depletion hypothesis. It's really interesting. So, yeah. So basically depleting inositol. Okay. Modulation of G protein coupled receptors. Okay. Lithium interferes with G protein cycling, particularly G1 and GS proteins. So lithium interferes with G protein cycling. It tends to reduce adenylate cyclase activity, lowering to lower CM peak levels. So it reduces adenylate cyclase activity, lowering CMP levels. This modulates signaling in dopamine, serotonin, and norepinephrine systems. Okay, so basically it interferes with G protein cycling and reduce adenylate cyclase activity, so less cyclic AMP, and so nothing's going to run as well. You basically turn the whole cell down by reducing the cyclic AMP. Stabilization of mood via dampening excessive excitatory transmitter. So basically it results in stabilization of mood via dampening excessive excitatory neurotransmitter. We're talking about excessive excitatory neurotransmitter. Okay, great. Next, effects on protein kinase pathways. Lithium inhibits glycogen synthase 3, a key enzyme in many cell signaling, including with insulin neurotropic signaling. Normal function, GSK3 phosphorylates various transcription and cytokeratin proteins, often inhibiting growth and signal and plasticity signals. Lithium directly inhibits GSK3 by competing with magnesium binding sites. The results increase neural protection and synaptic plasticity, promotes BNDF signaling, and supports mood stabilization neurogenesis. Yeah. So it inhibits glycogen synthase 3, and this results in increased neuroprotective synaptic plasticity, promotes brain derived neurotropic factor, and supports mood stabilization and neurogenesis. Yeah. Summary of effects in the cascade. So, okay, this is, okay, let me see here. The, okay, the inositol pathway. Basically, lithium inhibits inositol recycling, and that decreases intracellular calcium signaling, right? In the cyclic AMP pathway, it reduces cyclic AMP production, and it results in less overstimulation of receptors. It targets the GSK3 pathway. It inhibits GSK3, and it leads to more neurotropic and neuroprotective signaling. And then here, this Krebs and brain-derived neurotropic factor. It enhances via GSK3 inhibition. So you inhibit this, you get an enhancement of these, and this increases neuroplasticity and mood stability. Lithium is a very, very important medication to use. And so I think you should probably consider it when you're managing your patients. And I think that's all I have for now. I think it's a pretty consistent discussion, but I think you got it. So, please feel free to like, subscribe, and share. And if you have any questions about lithium, please feel free to leave them in the comments section, okay? Otherwise, it's been a pleasure talking to you guys. Read out. Take care, guys. Ciao.